Hi, welcome back to IU Radiology Case of the Day. My name is Nick Kuntz, and I'm a neuroradiologist and head and neck imager at Indiana University School of Medicine. And I'm back with another interesting brain imaging case of the day. As always, I'd like to start by stating that all of the educational content found as part of this presentation has been completely de-identified in order to protect patient privacy. So the history here is a patient who presents with personality changes, cognitive decline, and inappropriate behavior. We have three images to look at. The image on the left is a sagittal T1 weighted image. This is through the right frontal lobe. We have an axial FDGPET CT, so this is a fused axial PET CT. And then the image on the right is the sagittal FDG-PET data. So keep in mind the clinical history. Take a look at these three images. Tell me what you think is going on here. Okay, so what are the findings? And what's the most likely diagnosis in this case? So let's start by looking at the T1 weighted imaging. Again, we have a sagittal T1 weighted image. This is through the right frontal lobe. And what you'll notice, denoted here by the yellow arrows, is that we have disproportionate right frontal lobe atrophy. You can see the atrophy because it's based on the fact that we have enlarged sulci. Several of the arrows are pointing at sulci. And the gyri are getting very fine, very sharp. Sometimes this is referred to as knife-edge gyri. Now the same kind of finding is present in the superior right temporal lobe as well, but the atrophy here is not quite as severe. So you can see in the yellow arrows, yes, we have some prominent sulci that are starting to form, but it's not quite as bad as what we see in the right frontal lobe. Next up is our fused axial FDG-PET CT. And what you'll notice here, if you look carefully, is we have disproportionate frontal cortical FDG hypometabolism, particularly in the right frontal lobe. Maybe a little bit in the left frontal lobe, but significantly more severe in the right frontal lobe. Now compare that to the normal cortical FDG uptake that you can see in the parietal lobes, denoted here by the yellow arrows. So we definitely see that the FDG uptake is down in the frontal lobes, and it's more severe on the right than on the left. And to sort of drive home that point, we look at the FDG PET image, and right where this yellow arrow is pointing, we can see that it's a bit photopenic compared to the rest of the cortices. So again, we have that disproportionate right frontal lobe FDG hypometabolism. The right temporal lobe, as we saw with the atrophy, yes, it's a bit hypometabolic, at least compared to the parietal and occipital lobes seen here, but it's certainly less severe than in the frontal lobe. So let's put this all together. What's the diagnosis here? So this is a patient presenting with frontotemporal lobar degeneration, or FTLD, and specifically this is the behavioral variant FTLD. So this is a clinical subtype of frontotemporal lobar degeneration, and it's characterized clinically by progressive personality changes, oftentimes associated with apathy, and they tend to have loss of behavioral inhibition, so that's the inappropriate behavior that you may see, and they can also have repetitive motor behaviors as well. Typically, these patients will present younger than Alzheimer's disease patients. Frequently, these are sort of in the age 40 to 60 range. It gets a little bit more tricky once you get into the 60s, the mid-60s, because then clinically there's some overlap with Alzheimer's disease. Alzheimer's patients certainly can have personality changes, apathy, and even some of the behavioral inhibition as well, but not quite to the degree, not as classic as you have with frontotemporal lobar degeneration. So just keep in mind it may be a younger age of onset than we typically associate with Alzheimer's disease. And it's thought to account for about 10% of early onset dementia, or dementias that manifest before age 65. Something to keep in mind is that the laterality and the location of the lobar atrophy are really important discriminators when diagnosing the different dementias. It's an imperfect system. Nothing's ever 100%, but whenever you're approaching a dementia patient, try to figure out where it looks like they have atrophy, which lobes, is it left side predominant, is it right side predominant, and those can be helpful discriminators when trying to tease out different types of dementia. So in this case, we have a patient with behavioral variant frontotemporal lobar degeneration who had disproportionate right frontotemporal atrophy. There's another subset, which we may hit upon in a future case of the day, which is a language variant frontotemporal lobar degeneration. Those patients will characteristically have left frontotemporal atrophy, and in fact, that left frontotemporal atrophy can be broken down geographically into 3 distinct subsets, which can be helpful in predicting which clinical syndrome, which subset of the language variant FTLD the patients may have. So keep your eyes out, more on that in future cases. This is a nice paper that I think radiology residents and neuroradiology fellows really ought to take a look at. This was in AJR within the last couple years. And this was a nice review of the basics of the common dementias that we see as neuroradiologists. So a nice paper, definitely worth taking a look at. Okay, so let's wrap this up. This was a case of behavioral variant frontotemporal lobar degeneration. The key imaging features to know about that we saw in this case: on MRI, we saw disproportionate frontotemporal atrophy. It may be right predominant. It's not always going to be right predominant. It may be bilateral. It may be symmetric, but in this case, it was right-sided predominant. When you see left-sided predominant, be thinking more along the lines of language variant frontotemporal lobar degeneration, but certainly there can be overlap between the two. As I said before, it's a useful but imperfect system for characterizing these. There has certainly been a shift toward the use of voxel-based morphometry in order to compare these to age-matched normative data, to look at volumetric acquisitions of MRI and have a very data-driven approach to determining regional atrophy. On FDGPET, we'll see FDG hypometabolism that corresponds to those areas of atrophy, and in fact it may precede the volume loss as well. A couple pitfalls to keep in mind. While laterality and location of lobar atrophy are very important, you must keep in mind that these are imperfect discriminators when diagnosing dementias. So the imaging alone may not make the correct diagnosis. Again, I think these are incredibly useful tools. It's always something that I'm on the lookout for patients with dementia or memory loss, is trying to determine what lobes have atrophy, and if there is laterality, just keep in mind it's not an entirely perfect system. And I want to stress to you, clinical history is critical. You have to dig into the medical record in these cases. Your job as a neuroradiologist used to be just to say, hey, is there a structural lesion that may be causing these patients' symptoms? I think that we can reach further now. We can look at the atrophy patterns. We can formulate our thoughts, sort of come up with a list of things that you think may be going on in terms of what type of atrophy pattern you see, kind of come up with at least a brief differential. Do you think that this may be Alzheimer's dementia? Do you think this might be frontotemporal lobar degeneration? At that point, dig into the chart, see if it jives. And I think that the imaging really can be a powerful biomarker for these degenerative diseases, these neurodegenerative diseases, but you really do have to dig into the medical record and try to figure out whether or not what you see on the imaging in terms of the volume loss fits the clinical picture. Well, as always, thanks for tuning in to IU Radiology Case of the Day. You can always follow along on Twitter at @NAKuntz, and I would invite you to check out our complete collection of IU Radiology Case of the Day materials that can be found at radtf.iuhealth.org/COTD. Thanks so much.